While they're getting my slides up, I'll just kind of do a little bit of intro and talk a little bit about Health Rosetta in the background, and hopefully my voice lasts through the entire talking that I have to do. So I'm Sean Schantzen. I'm one of the co-founders of Health Rosetta. You're probably more familiar with my partner, Dave Chase. He's been a long-time DPC advocate. He wrote one of the kind of original white papers on DPC for the California Healthcare Foundation back in 2013. And even as I'll show you later, the Health Rosetta itself is made up of various components, and value-based primary care is our name for the various approaches to primary care that are significantly better for patients and for physicians and for everyone involved that either adds or buys value or receives value. And so today, the goal of my talk is to introduce a little bit about how plans generally work, some of the pitfalls for doctors as you start working with employers, some of what's coming with more robust plan design. If you heard Dave Contorno and Shane Purcell yesterday, that's a Health Rosetta plan, where we built a more complex plan where the entire plan was built around primary care out. And then Tina Wilt and Dr. Rohal that you heard yesterday, as well, is a Health Rosetta-centric plan. But healthcare plans are inordinately complex, sometimes for good reason, but a lot of times for no justifiable reason that I can come up with. Dave and I are both a little bit like insider-outsiders, that we didn't grow up in healthcare. Well, Dave grew up in healthcare, but we didn't grow up in benefits. And my background is I was early employed at Enterprise Software as a Service startup, and we grew pretty large and sold it. And then after we sold the company, I took some time off and went and practiced law and practiced securities law and worked for the guy that represented Ken Lay in the post-Enron stuff. So I've seen the worst of corporate governance, like everything we hate about the capital markets and Wall Street and all of that. I've read the Bloomberg terminals of the villains, and it doesn't hold a candle to what I've heard and been told about things in healthcare. Things that, very basic fundamental things, like the core of how employers purchase healthcare and the way that your average broker is compensated, and the amount of undisclosed conflicts that go on. Like I have FINRA licenses, I'm a securities attorney, I'm a general partner in a small venture fund. I'd be sent to jail for. And so there's a lot of really moving pieces complexity from all of this that makes it really hard to deal and understand how health plans are built. And so with Health Rosetta, what we're trying to do is I had it all teed up to do a perfect intro into my slide, and somehow I messed it up. Okay. Is we tried to step back to first principles. Like, what do we want out of a healthcare system generally? And then we went out and tried to find it, particularly Dave. He's been working on this project since 2010. 2011 is when he started writing online. And he and I together have been working on it since 2013. And about 2 years ago is when we decided to actually do something with it, as opposed to just being a kind of a project. And we said, what do people want out of a healthcare system? And we looked for successes. And so, and I'll describe a little bit about what Health Rosetta is in a sec, or the details of that in a minute. But Health Rosetta generally, think of us as three things. One is an open framework and taxonomy. So what we did is we went out and we talked to employers. We looked at Medicaid, we looked at Medicare, we looked all over, and we tried to find microcosms where things were working. And for us, definition of working is the quadruple aim. So the triple aim plus improved care team experience, whether that care team is your mom or your doctor. Because it's based on this foundation of if the people that are the experts that are supposed to be helping you through sometimes the worst thing that's ever happened in your life are miserable, they're not going to be able to help you very much. And so we said if something doesn't meet the quadruple aim, that's our primary lens, it's not even worth looking at from a Health Rosetta perspective. And so the framework and taxonomy is this ever-evolving work that we've been doing. Think of it like Wikipedia for purchasing healthcare, where we aggregate all these best practices, all these things that have been done, and then kind of abstract them into principles and guidelines and frameworks and things like that. And then on top of the framework and taxonomy, we're building two things. One is the ecosystem, which is what you probably, if you have heard of us, is what you know us of. And call that our yelling on the internet. So we write books. Dave's written two books that have been well received: The CEO's Guide to Restoring the American Dream and The Opioid Crisis Wake-Up Call. And we certify benefits advisors, and we speak, and we write, and we kind of do PR, and the benefits advisor certification program is probably the piece that's most relevant to here. There's 110 advisors. We screen them very heavily. We accept about 15% of people that apply. I personally interview everyone in the last stage of screening, so I've interviewed over 200 people to get down to the 110 that are in the program. And they represent 3.7 million lives around the country in 37 different states is where the advisors are located. So we've been quietly building this channel of early adopters, of people that are mission aligned, and we screen the advisors for three things: mission aligned, giver, and doer. And so we wanted people that were building things bigger than them. They thought they were working on building things bigger than themselves. They're willing to share that, and they're actually doing something. There's a lot of talking in the space, and so we try to avoid that. And then the second thing that we're building is a platform, and that's some of the stuff we'll talk about with Hint in a little bit, is how do you streamline and simplify adoption? How do you make it as easy to buy the good stuff as it is to buy the average stuff? So, so this is the main taxonomy of a Health Rosetta health plan. It starts with the way that the plan's structured, the plan design, the docs, risk management. So what you heard yesterday about MIWAs and this and that and the other, self-funded, fully insured, all those are wrappers. It's like bags from the grocery store. I could have a plastic bag, I could have a cloth bag, I could have a paper bag, but they're just bags. You can put whatever you want in there. You could have, I like to say that everyone always talks about self-funded versus fully insured versus this versus that. That's like, I have a bag of Legos in a plastic bag and someone comes to me, hey, why don't you put this in a paper bag? I'm like, well, I don't want a bag of Legos. I want the Empire State Building, and this is still a bag of Legos. And so until you fix what's in that, the wrapper sort of doesn't matter. Now, certain wrappers are easier to do in today's market, and certain wrappers are harder to do. Certain wrappers have different risk profiles that make them more appropriate for different types of employers or individuals or whoever it is. But at the end of the day, they're just bags. And what you put in the bag is what matters. And to us, primary care is the center of what should go in the bag. And then everything flows from there. And so another big thing is independent active plan administration and oversight. This is a really big issue of, there's enormous amount of conflicts in the way health plans are administered, where people make money in multiple ways. And it's at the core, it's like having a real estate agent that is both the buyer and the seller's agent. Like, they're getting, either way they win. And it's just really hard to be independent and support the people who are sponsoring the plan when there's these conflicts in place. And so those are kind of the wrappers. And I'll go over some really quick things. Individual stewardship, this idea that consumerism and kind of this leaving patients to their own like devices is a joke to us. Like, there's just no way that every time healthcare gets, even if you're thinking from a purely self-interested capitalist, like let's spend less money on this, so we can spend more money on other things. This idea, every time healthcare gets expensive, it gets scary, so people stop acting rationally. Like, if my son has cancer, I don't give a crap about bankruptcy. I will spend every last dime to save my son, and all of us would. And so patients need individual stewardship that they can trust, that's not conflicted with them. And sometimes that's primary care, sometimes that's about their benefits and the financial side, sometimes that's about a particularly complex episode. And you know all of your specialist friends, a lot of them aren't geared or incentivized or staffed to kind of help people with the journey of cancer or something like that. You see your oncologist maybe once every 2 weeks or something like that. There's a lot of other things going on, and it's the same for every sort of disease or any sort of episode. And so primary care is like a main part of that, but also people need experts in these specific areas as well. So individual stewardship is kind of this cross-cutting concept of people need help when they have complex healthcare issues or simple healthcare issues even. Then value-based primary care is the core of the plan of, ideally, it's not always the case. We're very pragmatic in how the health Rosetta is embedded. Sometimes it's not, there's not enough supply, the employer's not ready for it. So, but conceptually, it's the foundation of care. And then everything flows from that. And then transparent open networks, all this means to us is, and really quick, value-based primary care, of on-site, near-site, DPC, all these sorts of approaches. In our mind, at the core, it's smaller patient panels and economic incentives that encourage people to be able to spend time with their patients. Like various ways to get to that, but as long as those two basic foundational pieces are in place, it's already better than 90% of what's out there. Transparent open networks is basically known quality, known price, like value. Like what am I paying for something, and is it worth paying that amount? And that's the opposite of a traditional PPO network. So, and then major specialties and outlier patients, like again, complex healthcare needs specialists, and sometimes that's clinical specialists, sometimes that's health coaching specialists, sometimes that's navigational, sometimes a friend, sometimes it's mental health. Like, but plans should have specific strategies for, at least from a cost perspective, cancer or oncology, MSK, renal, cardiometabolic, specialty drugs, rare diseases, which would be transplants, hemophilia, anything that's like not frequent enough that unless you're at Walmart, you're not going to see very often. So you got strategies for that, and that's usually multi-solution for tackling that, because these are multivariate problems. And then transparent pharmacy benefits. We can all complain about PBMs. We know the challenges that come with that. We know the challenges that come from drugs being pushed on the market that don't have efficacy data that would efficacy data that gets them approved but doesn't work in any pragmatic sense of the word. We know all the problems with pharmacy, and so transparent pharmacy benefits is basically giving knowledge into efficacy and price so that people can make good decisions and plans can make good decisions about what they should pay for and what they shouldn't pay for as well. And then the core of this is kind of transparent aligned advisors. This is complex. Like, unless you're a gigantic company, there's just no chance. It's like playing whack-a-mole with a $3.2 trillion industry. Like, you're not going to win. United Healthcare will beat you every single time, no matter what. And that's not because every person in United Healthcare is like this part of this evil genius plan. It's just the system's set up that way. So that's kind of the intro to the Health Rosetta framework. Like, that's how we think about plans. And if you architect plans that way, then you're going to get results that are better. And again, better for us is quadruple aim. So why should you even pay attention to us? And what we do is, so this is a little old now, so I should probably update this. So we've written the 2 books, The CEO's Guide to Restoring the American Dream. If you want to understand health plans a bit better, read that book. It's a really good intro. They'll go into more depth than I will today. And then the opioid crisis wake-up call is basically we saw, whenever I say we about saw anything, any sort of insight, it's Dave. He's the one that comes up with what to do. I just figure out how to do it and how to make it replicable for us pragmatically. Dave saw the opioid crisis maybe four years ago or so as this like rising, like awful thing that at core looked like teed up with like a symptom from hollowed out primary care and mental health and other primary care-esque things. So we looked at it and we said, well, if you're gonna turn off, we've got to do all these things to like mop up the floor and all of the awful things that are happening to people that are already dealing with opioid overuse disorders and all the societal damage and everything. But you've got to turn the spigot off. I mean, the numbers came out from last year and it's not slowing despite all the talk. And the number of prescriptions, the number of people getting subjected to these is not changing. Unless you fix primary care, you can't turn off the spigot. So we said, let's take a variant of the CEO's Guide and take it and apply the concept of the Health Rosetta to a specific public health crisis that is tangible, that people understand. Like, everyone knows someone that's been affected by the opioid crisis. We've had CEOs of Fortune 500 companies reach out to us cold, and lots of other kind of powerful people, as it were, saying, this is amazing, I never heard of anything like this. I never connected those dots before. And so those are the 2 books. We sold over 20,000, I think it's probably 25,000 or so, something like that now. And so they're out there, the books, and that's part of our strategy is get things out there and create more fertile ground so that 1,000 flowers can bloom. How you tackle healthcare in Dallas is different than San Francisco and even within Dallas. If you have a 300 employee national trucking company where people could be anywhere in the country at one given point, or a law firm, those are different companies, and yet they buy the same health plan, which is absurd. And I could go on and on that issue, but I'll avoid that. The second thing is, and this is probably the part of why doctors should probably pay attention to us, is We spend an enormous amount of time. Hundreds and hundreds of people have contributed to the Health Rosetta in one form or another. Dave and I are meticulous note takers, all the way down to every time I hear about a vendor or solution of something that could help a plan, I take a note of it. And so I have over 350 different vendors. And that's not, and I don't write down individual DPC clinics because I know I can just call Zach or Mike and be like, hey, who's here, who's doing this, and they'll tell me. But so this is everything else, so not even individual clinicians at all. And tons of these people have clinicians and policy leaders and plan sponsors. Plan sponsors is like term of art for the person that's putting on a health plan. So it could be an insurance carrier or an employer or whoever. They're the ones sponsoring the plan. And plan sponsors, HR leaders, patients, patient advocates, all sorts of people that have contributed to this. If you go on our website and click on who we are, we have our team, but we try to make it very clear we're an ecosystem, so you'll see dozens and dozens of people listed that have been very significant impacts and help to us. Garrison and Dave, Garrison's been enormously impactful on Dave of helping him understand DPC, and the fact that Garrison and Erica live in Seattle has been all the better to help him understand that for years and years. Rishika from Iora, like a number of people that are leaders in DPC have been very influential in helping us understand the role of primary care. And we try to listen. Like we think of what we're doing as we're playing one giant game of King of the Hill, and whatever King of the Hill is at any given point, that's what it is. If something better comes along, great. Like we're not the smart ones in the room on all these things. We're just trying to pull it all together. We have enormous reach, which actually helps with the contributions, is because, and I use social media as like a proxy, but we reach. Actually, now this number's we've had about 87 articles placed about us in the last 8 months, 9 months. Since last summer. And what that does, and all this social media reach and everything, is it means that we get market intelligence. People tell us what they're working on at a scale that I've personally never experienced. And even, and I'm gonna give Dave kudos, and that, even though I know he wasn't this strategic, but the books have been written in a way to kind of incite people to think about things that they've, and kind of also air out kind of frustrations that people typically feel in the healthcare system and bring different stakeholders. And so we get people reaching out asking about almost like catharsis for them. And so we get to hear what people really think. And I joke around sometimes that my favorite people to talk to are slightly intoxicated former executives of major healthcare organizations, because they stop towing the line. And they have no, they stop towing the line, their inhibitions are down, they have no horse in the race anymore. And so again, certification, 3.7 million lives, 110 advisors, 37 states, largely mid-market. Many of them are here. Some of them had to go home with their families and everything before today. But this is how we source our insight. This is how we make sure that we understand what's going on in the market on a cross-stakeholder basis, and we're not, at least hopefully not, falling into too much of our own opinions on things. Okay, so that's kind of Health Rosetta. As a concept and as what we do, we're half nonprofit, half public benefit corporation. We were entirely nonprofit until this summer, but everyone kept asking us to do more and more things, all the way down to people asked Dave and I to start a TPA. Multiple very smart people who I deeply respect said, you guys should start a TPA, which is a third-party administrator, a plan administrator. And I stepped back and went, whoa, what on earth about Dave and I's background indicates we have any business running a TPA, and more importantly, any interest in running a TPA? And it sort of made us step back. And so we expanded the nonprofit. We started working on this platform, which we'll be talking about later, that's meant to simplify adoption of the Health Rosetta. And that's why we created the Public Benefit Corporation, because we couldn't legally do it under the nonprofit, because it doesn't look like charity anymore. But it has built into its fiduciary duties the same mission as our nonprofit. And what that does is it helps us ensure that we're not going to drift from our mission, which our mission is to replicate grassroots adoption of practical, proven, pragmatic fixes to our healthcare system, to the root causes of dysfunction in our healthcare system. So I'll pause right here, and from here on out, I wanted this to be a lot more interactive. I know it's hard with me sitting on the stage with this freaking light right in my eyes, but I want to make it as interactive as possible, because health plans are really complex and they're really multivariate, and you've all come across, and I couldn't possibly cover all the different areas They could, and those that know me know that I could talk for the next 40 minutes on it and fire hose it all onto you, but you wouldn't leave remembering any of it, and a lot of it wouldn't be relevant. So rather than doing a kind of academic rundown of health plans, I want to kind of go through some major things. I'm going to pause after each slide and ask questions, and please feel free to answer or ask questions, and no question is too simple. There are no stupid questions. Like, this stuff is really hard. I came from outside of healthcare, maybe 3 or 4 years. I probably had as much knowledge about health plans as you all do. It's taken hundreds and hundreds and hundreds of hours of studying and interviewing and working with people to really understand how they work. Luckily, I'm a securities attorney by background, so I like wonky, complex stuff. I also have a background in the capital markets as a securities attorney and some other things, so I understand insurance and risk management pretty well for like a non-underwriter, non-actuary type person. But this stuff's complex, so I'm going to pause after each plan. And I'm going to pause with the bags. Like, what are the bags? And yesterday you saw like some specific bags, but those are all, step back a little bit from that. Those are specific statutory frameworks for types of bags. And the bags, at the end of the day, are ways to manage risk. Because if you're a 150 employee company, and you get someone that has hemophilia in your population, like, game over. Like, there's nothing you can do because the drugs are expensive. And there's things you can do to better manage it, and there are specialists that do this, and there are sources of drugs you can get slightly cheaper. We're talking like, oh, it's going to be $800,000 a year, not $1 million a year, or whatever the exact numbers are. But hemophilia is roughly around that magnitude, just for some context. It's pushing $1 million a year in some cases. And so the bags are all about risk management. And so you have fully insured, which is the traditional model. And everyone likes to bash on fully insured. You'll even hear some Health Rosetta advisors and other brokers like, oh, everyone has to be self-funded. No, if they're really good fully insured products built on the Health Rosetta, then that's fine. And there are things moving in that direction. And things that are fully insured and fully insured-esque. So when you hear like a Sedera or a Decent or things like that, those are like, maybe I should have a fifth one that's like alternative funding mechanisms. Those are sort of full, they're intended to solve problems for people that the alternative is fully insured. They're not, the bag itself is different, but they're trying to tackle the same problem as fully insured groups typically. So there's fully insured. Kind of the next level up from that is like fully insured on steroids or self-funded junior, which is level funded, which you're starting to take on a little bit of risk, where you're technically self-funded, but you're paying out certain premiums every month. But if you don't use, if fully insured, you pay your premiums and that's it. Like, if you don't use very much, like, someone buys a yacht. Whereas in level funded, even the worst level funded products, you at least get some of that money back. Like, United Healthcare has a product out there called All Savers, which is not that bad. Like, for a conservative employer that wants to start dipping their toes into more complex healthcare structures, you get 50% of, if you pay $1 million in premium, but you only have $600,000 of claims and administration fees, that $400,000 that's left over, you get $200,000 of it back. So even United Healthcare, who is everyone likes to hate on United Healthcare, no matter who you are, it's moving in the right direction. Now there are level funded plans that are 100% pass through, and in our mind, like 100% is better than 50%. So that's level funded. And then the next one is partially self-funded, and that's the majority of the mid-market. Most employers under 10,000 employees, and nearly all employers under 5,000 employees, are partially self-funded. So when you hear people talking about stop-loss insurance and things like that, like you heard Spencer from LA yesterday, they're great, we're big fans of them. What you're doing is it's reinsurance. And does everyone know what reinsurance is? It's like insurance on insurance. And what it is there's two types of it. And Spencer covered this yesterday, so I'm going to skip that. But partially self-funded. And then there's fully self-funded, which is everyone above 10,000 employees, roughly. These are all rules of thumb. And that means you take on all of your risk, 100%. And so if you're Walmart and you have 1.5 million people on your plan, you take on all of your risk because you have thousands of cancer patients per year. And actually, normally people, whenever Walmart is brought up, it's to hate on them, justifiably so for lots of reasons. But when it comes to their health plan, they're probably one of the best, if not the best, effectively managed private health care plan in the country. The way that they've tackled centers of excellence and complex care is like unprecedented. Like they've been at it for so long for a plan that size. They're like little, like there's a 500 employee company here, a 1,000 employee company there, but to be able to do and consistently manage their costs for a population that makes $10 an hour, like you actually get pretty good benefits if you work at Walmart. That's actually one of the reasons behind the scenes you see a lot of greeters and other things working at Walmart. They have really good benefits for, especially for complex things. Like they'll fly you to Mayo Clinic to diagnose, have a second opinion of your cancer. Like they'll do a lot of really cool things. So that's fully self-funded. So I'll pause right there. Any questions? Have you heard, any, not even just questions, if you run across like rappers where people have come to you and said, hey, you should participate in this, you should add this to your thing, and want to ask questions about it, like a Sedera or something like that. There's certain people that are known here in the community, and anyone that's in the community, I generally know most people. We generally think of them very highly as well, like all the people working on various plan structures. So you can generally rest assured that from our perspective, from a plan perspective, we're like the aligned plan side for you guys. Like we're hint for plans. We're generally fans, but there's lots of others going to reach out to you. One of my biggest frustrations right now is all the people trying to build networks coming out and saying, I'm going to pay you whatever, $50, $60, and I'm not really going to do anything other than bring you customers, and I'm going to charge employers $100. And I look at that and I think, what? There is value in aggregating contracts and putting together. It is not $50 per employee per month of value. That's not the same as like the Nexteras and the Stratas and all the other kind of more like infrastructure-based, I'm not going to use the word corporate DPC, that's wrong, but the more growing building networks, because they're adding value. They're your peers. That's different than these kind of interlopers. But yeah.
All right, can you hear me now? Could you elaborate on the difference between insurers and third-party administrators? They sound like the same thing to me, but I think there is a difference.
So we think about problems to solve. We always talk about problems to solve and move from there. That's one of my frustrations with the healthcare industry generally is solutionism, is everyone starts with like the shiny object, oh, this is cool thing, this cool thing. Health plans are notorious for this. So we start with problems to solve typically. Like what's the problem being solved? So the problem being solved by all of those is someone has to collect money from the employer or from the member and pay doctors and answer the phone when members and providers have questions. So that's the problem being solved. And so people solve that in various ways. And so there are basically three in the market. This is the bulk of the market. There's exceptions to this, but there's three main types of ways to administer your plan. One is a carrier-owned plan administrator. And this is in the self-funded world. The carrier-owned plan administrator. That's like United Healthcare, Blue Cross Blue Shield. They're the person that's doing that, and that's the same for fully insured. They're the person paying the claims, answering the phone, all that sort of stuff. The second type is carrier-owned TPA. So that's like UMR, Meritain, Allegiance, HealthScope now. They're separate companies, but they're owned by a carrier. So they have more flexibility in what they can do, but not as much as would be ideal. And then there are what are called, and even within carrier-owned TPAs, there are some that have much more tight controls from their parents, and some that have less. If you're owned by a regional HMO, is Nova still here? I think they might have had to go home. Oh yeah. So Nova Healthcare is a TPA over there, and technically they're carrier-esque owned in that they're owned by an HMO. It's not a full carrier, but that's not the same as being owned by Aetna. So there's even a continuum of that, and basically the less powerful and large the corporate parent, the more flexibility they have as a rule of thumb. And flexibility means they allow the employer to change their plan design and documents. They'll work with DPC and other point solutions. They'll allow more flexibility for the employer. And then the third category is independent TPA. So these are third-party administrators that are not owned by a parent. And typically, and this is again rule of thumb, and the exceptions all prove the rule, is they're the most flexible. And they're probably the ones that if you want to build the most sophisticated DPC-centric plans, you need to have an independent TPA. or like Nova, they actually have a lot of DPC experience. They have they have the most flexibility. Yeah. Does that answer your question? Probably more than you wanted. But that stuff's actually really important because a TPA can make the difference between working with an employer going great and killing it. Because if the TPA doesn't want to actively work with you to figure out swim lanes between you and maybe there's some medical management or something like that, and pharmacy issues, if you're dispensing, and is that being paid by the patient or not? Are you paying for it out of your fee? And a TPA that's not willing to work with you, at least on figuring out how we're going to do things, it's going to create a bunch of noise for the HR leader. And HR leaders hate noise because their entire job is to keep noise away from the CEO. And I feel I have a lot of empathy for HR leaders because they're expected to don't get us sued for sexual harassment, don't let OSHA shut down our factories, make sure we hire and retain a bunch of freaking Albert Einsteins. Oh, and by the way, on the side, why don't you manage our second or third largest P&L line item of healthcare that also significantly impacts our things? And you know what? You majored in communications in college, not physics. It's just not fair. And so, justifiably so, they toss it off to their brokers. And most brokers are not taking that responsibility with the gravitas that it deserves and how much it impacts people's lives. And so that's why I gave a little bit more detailed answers, because that's actually one of the things I was going to hit on later is what the differences of these are. These are very important issues that you don't necessarily directly control, but it's things you should be looking for if you're trying to build the most ideal plans around DPC or be participating with employers. And when you tell an employer, you got to move to an independent TPA, if a broker is this credible and I'm maybe like this credible, I moved my fingers a little bit, you couldn't see. You're this credible because we all love and care for doctors. We've all had a doctor in our lives or in the lives of a loved one that's helped us. And outside of it, and I'm an attorney, I'm a member of a cult just like you. I went to a school that taught me a very specific way of thinking and indoctrinated me, and there's nothing I can do about it. I'm scarred for the rest of my life, positively and negatively. So all of these nuances you make between specialists and everything, the rest of us don't care. It's like doctors, so we trust you. So whenever you work with brokers, make sure they bring you to meetings. That's one of my other points later on. All right, questions, other ones? You can yell, I'll repeat it.
Have you looked at how Health Rosetta would interact with like the Buffett, Amazon, or the Schantzen program, and or the Michael Milken Institute doing so much about trying to find new doctors?
Yep, yeah, that's what I was going to. Okay. Do you want to repeat or do you want to? Yeah, you can repeat so I don't mess it up.
Hello. Warren Buffett and Amazon and Goldman are putting together their own, perhaps, solution to all this. Seems like Health Rosetta would be a really good participant there. And the same goes for the Michael Milken Institute, looking at future models for the entire healthcare system.
Yeah, so two comments. So one, part of ecosystem, we like to stay too small to pay attention to until we're too big to ignore. That's part of our strategy. And we are involved, most things that you've seen publicly around big employers doing things, we've been involved in one level or another and I don't talk about it. My second comment is, this is a little bit personality of Health Rosetta, so you just get to know is, we might publicly like pontificate and talk about other things, all this sort of stuff. Like we can be very high-minded on how to fix healthcare when you read stuff from especially Dave. But on the ground, this is Dave included, we have very little patience for pontificating. Like I have so much more respect for the most junior DPC doc that is broken away, especially since you're indoctrinated to be risk averse, because when you take risk, people die. When I take risk, people don't die. Like people lose money at worst. That anyone that breaks out of that and does, I want to listen more to them than I do to someone pontificating but not necessarily doing a lot. So I like the Milken Institute a lot. They've done an enormous amount of good work. He's really made up for the 80s in what they've done. But we don't pay a lot of attention to that around our strategy because they're not on the ground actually doing things. And healthcare at the end of the day is local. So I actually pay more attention to microgrids and energy and food co-ops, agriculture co-ops, and buy local movements and things like that. Anywhere where there's relocalization of healthcare, we look for it. So That's kind of my two comments. But yes, we think primary care is very much involved in that, is a big piece of that coming. The challenge is everyone wants to go big in healthcare. Like, it's wrong. Like, it is so hard. Like, I won't say who it is. There's a major, like, we're talking like Fortune 50 company that I know the head of benefits pretty well, and they, between retirees and employees, because technically each state, I won't get, insurance law is different for each state, so it's managed each state. So technically, and this isn't totally true for all of you plan folks in the room, so except I'm not giving the actual full answer. Essentially, they have 300 plans across 50 states to cover their employees and their retirees. And so for them to even do anything, it's hard. And so our favorite people are 100 to 2,500 employees. So I would stay away from big employers as DPC generally, unless it's something local, like Strata with the stuff they do in the state, that sort of stuff. That's a lot more pragmatic than like Fortune 500 companies or even Russell 2000 companies even. Any other questions on that point? Okay. See, I was just about to do that. So carrier-owned TPA, I call it fully bundled, but that's basically like carrier-owned TPA. There's very, very, very little flexibility. So even if they're self-funded and they're with Blue Cross, and that's generally Blue Cross, someone in the audience correct me if I'm wrong, Nova, Tina, everyone. Blue Cross doesn't have it, the Blue Crosses that are both independent and the big ones like Horizon and whatnot, and Anthem and all those, they generally don't have like separate independent TPAs. They're separate companies. I think there might be a few exceptions to the rule around the country, but generally they don't. It's the Aetnas, UMRs, all of those that have those. So we've already talked about that, so I'll skip over that. Okay, so the basic players in a self-funded plan are your TPA, your third-party administrator, and the third party is third party as to the plan sponsor. So generally the term TPA refers to all three of those ones I talked about before. There's your PBM, which is manage your pharmacy benefits, and that's why you have two phone numbers on member cards, because it's different organizations that manage them. There's your network, which is your physician access, and typically it's PPOs, but that's just one way that we've ordered it. And we all hate on PPOs, but conceptually, there's nothing wrong with a PPO if it were structured in a more transparent way or some other things, didn't try to like beat down employer or doctors. And then there's your risk management structure. Like, are you using stop loss? Are you using a captive? All those sorts of things. And then the people. We always like to forget that the plan sponsor exists to serve the people, even from a fiduciary duty perspective. ERISA is my favorite law in the country. And the reason why is it's been around since the Ford administration, and no one understands it, and no one's gonna change it, which makes it really easy to fix healthcare by way of it, because it's super complex. And there's a ton of good analogies. Basically, ERISA covers any employee benefit. And so the same fiduciary duty that covers 401k plans is what covers self-funded insurance plans. And we think there's some big levers for fixing healthcare because of that dynamic that you can talk to me offline if you care about that sort of stuff. But these are the typical main players. But the plan sponsor exists to serve the beneficiaries, which are the people. And I think that's something that gets missed on talking about plans, is that they have the same things as you do, except for they're statutorily required to serve their people. Now, they're statutorily required at it, but as a whole aren't as good at it as you. You're not statutorily required at it, but as a whole are better at it than they are. But you have the same goal. That's the intersection between the plan and you, is you both have an ethical or fiduciary duty obligation to your members that's defined everywhere from your heart to ERISA. And that's where we think the overlap is. So that's a typical plan. You saw this. An ideal health Rosetta plan looks like this, which is quite different and quite more split up. So transparent open networks, like I said, physician access at the end of the day. That's all it is. Like, to me, I come out of technology. Network's not a bad thing. Networks are awesome. They're what makes the modern world work. They're powerful. Networks have this really cool dynamic where every time you add a new node, a new endpoint to a network, the more powerful it becomes. Imagine if only a third of us had telephones in this. Telephones would be less valuable to us, but because all of us have telephones, they're more powerful. So it's based on a concept called Metcalfe's law, which defines this idea that networks become more valuable the more people use them. And so in our minds, networks done in the right way are really, really valuable. They're just a byword because they've been not very valuable in healthcare. We went through this, I won't go into this anymore. So now kind of pragmatic, and this will get into more questions. This is how we think about things. So a traditional plan is like a misshapen Mr. Potato Head. Technically it has everything you need, but it's not really what you want. So what's happening, and we have this weird luxury at Health Rosetta, is that we get to just sit back and look for cool things happening and then dive in and help those cool things happen. We're not sitting in a particular geography like having to I've got to fill my clinic and I've got to do this so that I can feed my family and did I make a horrible mistake by leaving practice, and am I going to be able to pay for my kids' college, and if you're a younger doctor, am I going to be able to pay for the $400,000, $500,000 of debt that I have between going to a fancy private art undergrad or private school undergrad and a medical school? We can step back and see what's going on. So what we're seeing is that everyone is trying to unbundle the plan. And what that means is everyone is smart around the country and is looking and saying, well, that sucks, I could make that better. Well, that sucks, I could make that better. On everything to do with healthcare. And some of it is here in San Francisco, and it's very high value, or very high, kind of high buzz, yeah, that's a good word. And we all tend to look at it because it's what we hear about. But I actually think that the most interesting things is like what you guys are doing on the ground, like solving the actual problems, doing the ditch digging. And so what's happening is everyone's doing this, and so everyone's unbundling. And so what we've got is we've got a bunch of pieces on the ground. And we're all going around telling one, I can build Superman, Mr. Potato Head, and I can build Wonder Woman, Mr. Potato Head. And so what we think the challenge is that you got to assemble that all back together into something new. And that something new should maintain its flexibility. So that example of Dallas, the trucking company versus the law firm, they get different plans. That's where it should go. That's where it needs to go. And that's frankly where it is going. If you heard the case studies yesterday with Tina, I flew out to Lancaster just to help put together the network and sit there and listen to Tina and the CEO and the CFO and Dr. Rohal and everyone and watch the dynamics last fall, because that's where the real interesting things are happening. And so this is hard work. There's a lot of things, just the basics. Imagine there's 15 vendors in a plan. That's 15 contracts. That's 15 ways that the contracts might disagree with this plan summary plan document, which is the governing ERISA document for a plan. That's 15 sets of member education materials. That's 15 sets of TPA customer service materials. That's a lot of annoying crap. And that's just the tip of the iceberg, is just the logistical lift of putting it all back together. So we think this is the thing that's slowing down the adoption of everything that's being unbundled. And that's a systemic problem that no single person can solve. And so, does that analogy make sense, Mr. Potato? Like, any questions about that? And when I say unbundle, I mean, it could be different disease areas or care areas. It could be the machinations of putting the plan together. It could be risk management. It could be all sorts of the network, the PBM, so Anderson County that you saw yesterday with Shane and David Contorno, they have 5 different formularies for that plan for pharmacy alone. Dr. Purcell prescribes things. There's a domestic mail order. There's an international mail order for brand and specialty. There's the PBM's normal way, and there's a default TPA or PBM mail order. So there's 5 different ways to get drugs. You can imagine the complexity of getting that to the members. But the net is that together those things can reduce drug costs while increasing or maintaining the quality of pharmacy by like 40, 50, 60%. So it's worth it, but it's a little harder. Okay, so dang, I'm getting ahead of myself. So here's some sorts of things where that complexity comes up. I'll jump over this. We're basically building a platform to simplify. There's a difference between having a bunch of parts of a car in your garage and going on vacation with your family in that car, and it's not any one thing. It's thousands of little things, and tracking all of those, ensuring they're all good, ensuring they coordinate, and then know how to do it. And this automation, the simplification, basically we're building all the things we heard about Tesla and all their issues of getting their cars built and for learning how to be a manufacturer. We're trying to figure out how to do that for unbundled health plans right now. And the way our platform works with our advisors is like RoboCop. We're the robo, they're the cop. You can't be RoboCop with only one of those, so we are building RoboCop. This is a really good thing when you're talking to employers. I think it's like a frog in a pot of boiling water over the last 40 years, where no one stepped back and said, hey, maybe we ought to optimize how we manage this huge spend. And so it's this disjointed shopping and new shiny objects, and you're probably seeing that with DPC, where you get brokers that just want something to sell. Or you go in and you've embraced the fact that, like, well, if I'm the shiny object, I'm gonna go dance the dance and win a bunch of customers and then use that mechanism to do the right thing. But it is a lot of shiny objects, disjointed data, very reactive. Like, something bad happens in my plan, let's do something about it. Like, which is ridiculous, because we know, I mean, go to a long-term disability insurance carrier, and they will tell you exactly how many member life years, on average, each thing happens that's bad. We know this, we can predict this, yet no one's really done this. And so we think of this as being, you have to have this virtuous cycle. Similar to how you run your own businesses, similar to how these businesses run every other part of their businesses. Like, you go to a company and you're like, oh, you vertically integrated an entire global supply chain and you can't fix your healthcare plan? Come on. Like, that's a joke. Like, you built an algorithm that indexed the entire world's knowledge, Google? Come on. Like, we're not talking rocket science on this stuff. It's just bricklaying and doing it over and over again and paying attention to who you believe. So in the Health Rosetta world, this is the plan lifecycle summary. But it starts with the plan sponsor and member needs. And those needs have a foundational similarity, but are different. Like, a bunch of 28-year-old software developers in San Francisco have different needs than truckers. All right, so value-based primary care-centric plans. From a plan's perspective, you guys do 3 things that the plan cares about. And again, I'm trying to bridge the gap between what you care about and what they care about. And so they care about these things. They want day-to-day acute care managed and managed as conveniently as possible so that their workforce is more productive and happier. And they want for them and their loved ones, like especially populations that have high percentages of women in their workforce, because unfortunately, women now make up like a bunch of the workforce, but they're still doing like 80% of the stuff at home, as you all know. And that means doctor's appointments for the kids, and they're sick. That's more time off, that's more this, that's more that. Companies hate that because there's lots of evidence that companies that have more diverse boards of directors, executive teams, everything, perform better on every metric you could come up with. And so day-to-day acute care, so that's more of a convenience and perception of high quality benefits issues. There's an emerging and latent risk, population risk. Everyone likes to focus on diabetes and this, that, and the other, and cardiometabolic, but the reality is most spend around cardiometabolic is heart disease, transplants, like all of that, the drugs, all of the like wellness, like eat better, sleep better, like work out. It doesn't affect things on a timeline that economically employers give a damn about. Because unless you have an average turnover of 10 years, they just don't care. They think they care. They may even tell you they care. In fact, they will tell you they care. Economically, they don't care, because none of the things that go into that sort of stuff matter. So, but that's bad for care. So how do you deal with that? So the idea is to think more broadly instead of these specific disease states and say within a population there's emerging risks and there are risks that are laying dormant of something that bad that could happen. And this is for you all you don't know this 100 times better than I do. There's the people that you know, like things are going to blow up for you at some point, and I don't know when. It's tomorrow, it's next year, and the employers want to minimize the number of people who blow up on their clock. Like, and I'm thinking economically. Like, this is my capitalist hat on, not my like, I love my children and I love the world hat. And then the last thing is navigating complex conditions and episodes. As I said, healthcare is really hard and complex. So, primary care just has like. Has everyone heard of a term called utilization management or utilization review? That is a stupid way of saying, and a stupid Band-Aid of replacing you saying, I think you should probably do this. That's it. We spend billions of dollars a year on this crap every year. Now, again, there's a very good TPA in the room that very much agrees with me on this. There are other plans need to be audited, if nothing else, for compliance perspectives. And not all doctors are all of you. We know that. Not all healthcare systems are all of you. I've been multiple times, been having lunch with a physician friend, and they've gotten a notification from their app on their EHR that's like, last month you were at 15 RVUs. This month you're at 9 RVUs for the month, or whatever the number is. And I'm like, what are you, a cell phone salesman? Like, I would never do that. So there is a role for this stuff, typically not with primary care, and typically not for this, but this is navigating complex conditions and episodes. And backing up, the different plan architectures impact each area differently. Okay, so now how do advisors decide to do or not to do DPC? And this is one of the first problems we're solving with the HINT partnership is advisors don't want to lose their customers just like you don't want to lose your patients because they like their customers, they like the money that comes from their customers, they like having a job, they like paying for their mortgage and all these things. And so every year, there's like this annual kabuki dance where everyone gets together and figures out what we're going to do with the plan. And the advisor has to decide, what am I going to show or not show to the employer as an opportunity? What's the shiny object this year? And even the Health Rosetta advisors have to do this because they have to have a hook. Even if they're thinking more strategically, they've got to have a hook to get it. And so basically every other thing in the Health Rosetta is easier or is less risky to propose to a plan sponsor than DPC from a can I do it perspective because of the supply and demand issues in the market right now. They're not matched up well. And so the first thing they've got to decide, is it possible in my geography and is it possible for this client? So that's one of the first things that we're working with HINT is the ability for the advisors to go in and see, is this possible? Because then they can say, cool, I can go in and propose DPC and I won't end up with egg on my face if I educate them all about it and then it turns out we don't have supply to meet where they're at. And so that's that. And then that then leads to, well, what's the right approach for this? And then including the docs to get the employer on board. Docs should be including you. Advisors should be including you in their meetings because you're more trustworthy and persuasive. And you should be including Health Rosetta style advisors. And I'm not saying every good advisor, broker is in Health Rosetta someday, hopefully, but not yet. Is in your meetings to help ensure that they put the plan structure in place that's going to allow you to thrive. Because I know a number of you if you've complained to me about deals have gotten kiboshed by brokers. So getting together is going to be a big part of it. This is the complex part. This is the most complex slide of this. And I don't expect everyone to understand all of the details of all of this, but I hope this is. Think of value-based primary care could be three things. Bolt on, which is probably what most of your employer thinks you're doing, is they have a high deductible plan and then DPC, and they just take the tax hit issues. That's why everyone's focusing so much on the HSA, HRA thing, because that's for bolt-on plans, because that's the reality of the individual market, and for you, it's the most easiest thing to solve. The problem is it doesn't really save money. It improves care, there's lots of other reasons, and there are lots of employers who will do it just for that reason. Like Tina talked about yesterday, like they don't know exactly what the ROI is going to be. The employer's doing it because they care. And they're not even doing a bolt-on, they're doing more of a bolt-in, where they do have some other things, the employer is paying for it. So bolt-on is basically an independent insurance product and an independent DPC coming together. Bolt-in is a typical plan structure with DPC built into it, but not much change to the underlying rest of the plan. Built around is saying primary care is at the center, everything flows from that. And so that's what we want seeing, because that's where you're gonna have the most impact on cost and quality of care. That's where you're gonna achieve the quadruple aim. That is orders of magnitude more complex to do than the bolt-in and bolt-on models. And built around doesn't have to be just self-funded employers. That's what you heard Decent talking about, and Sedaro's doing some of that, and lots of other people are trying to do these things. MyMD Connect, so Jeremy's gone now, but Dr. Smith, he ditched us for Napa, he told me. That sort of stuff. They're trying to do more built around things, but most of the stuff you're seeing out there, and most of the people that will come to you, at best it's a bolt-in. Mostly because most brokers don't know how to build built around type plans. But that's where it needs to go, is where primary care is like air traffic control for the rest of the plan, of the care side of the plan. And that's probably what you want to do. Your patients get cancer. You want to ensure that that entire journey of cancer is optimized at every point of the journey. But you don't have the ability to do all of that. Like, the NCCN guidelines are 40,000 pages of clinical jargon across 200 cancer types. Like, that's impossible for oncologists to be experts in all of that. And then the oncologists tell me, well, the NCCN guidelines are like 3 to 5 years behind. I'm like, but how are we ever going to tackle this? But there's specialists that are focusing on that journey of cancer issue. And I use cancer because it's just such it's like the most common of the rare things. And so we all know and we all understand a lot. Okay, so, how to work about. So what they care about, we talked about that, showing ROI. Think about what you can directly impact, what costs you replace, and then what you directly impact, ideally on a 12-month basis. Like talking about like we're gonna impact like I said, cardiometabolic stuff is like the poster child for this. The timelines are so long that they care about it, and they tell you they care about it so that they can sleep well at night. Economically, they don't care about it. And then what can you indirectly impact? And so of those three things, the more latent and emerging population risk and the more navigating complex disease or chronic conditions and episodes you can do, the better ROI you can show. And any of you that have good ROI models, we want to see, because we want to make sure we can figure out how to translate this to employers so that they can see that. And we can show it to underwriters and they can see it, because that's one thing that could kibosh deals is you go and you sell and you say, hey everyone, this is really, really great. DPC is awesome. Maybe they come visit your clinic and it looks awesome. They're so excited, blah, blah, blah. And then the broker takes it to the underwriter and they take it to the wrong underwriter. The underwriter doesn't believe anything about DPC. Maybe you've never even heard of it. And so they're not adjusting the aggregate claim factors, as you heard yesterday. And so therefore, the employer says, well, you say you're awesome and you say you're going to do all these things for me, but the person bearing the risk says no, so I don't know what to do. And they end up punting for a year. Next year, like that's always the issue with health plans, next year. And the biggest way to keep in mind of this is the spend distribution, and basically it's a hyper Pareto distribution. A very, very small number of members in the grand scheme of things cause a very, very large amount of the spend. And so in order to provide better care, we've got to embrace where the money is going and the flow of funds and build around that. And luckily for our ethics, for all of us, in our morals, is that those things that cost the most money are also the things that are most human, have the highest human cost as well. And so addressing them is where you tackle most of the human suffering and financial cost. And so the more that primary care can mature to help out with that and reconceptualize and embrace primary care as being the umbrella for all care, then the more the employers are going to be getting on board. And the way that we think about this is individual steward. You have the general steward, which is the person that's ideally value-based primary care, that's like their navigator for everything at the starting point. But then they're like Grand Central Station. They're handing off for various things that come up, hospitalization, procedures, and some of the stuff you can handle yourselves and you're very well equipped, or maybe even extender that does it. And then some things, the plan ought to have things in it so you can hand off that do it well and do more than, like, in our ideal world, when you hand off to the specialist for the referral, but you hand off to a navigator that's a specialist in that as well. The market's not quite there. It's getting there. We saw potential pitfalls. Last thing, broker sophistication. There's a lot of snakes in the grass in the space. Anyone that's, I'd say positive. Anyone that's trying to take what seems more than their fair share, which means anything that's looking like anywhere approaching the amount of money that you are getting out of the deal, probably not a good idea. And I know it's tempting, but it's just, yeah, I mean, it's rent-seeking behavior. Okay, so questions. What can I, where do we want to start? I'll start with where the mic's going first.
Thank you. That was tremendously informative. I'm curious about a couple things. Can you talk about how brokers are compensated in the Health Rosetta model?
Oh, so I thought you were going to stop how brokers are compensated in a way that would send me to jail in the capital markets. So in the Health Rosetta model, we, okay, so brokers are paid, default rule, brokers are paid by insurance carriers. That's the default. In the self-funded world, they're typically their compensation is layered in on a per employee per month basis on top of the plan administration costs. And so it's generally somewhat known, but there's a bunch of back-end compensation. There's bonuses, there's what are called overrides, there's retention bonuses. Basically, if you keep people, the more people you keep with a particular carrier, you get additional bonuses. Like, so that's the default way, is that they're paid by commissions and fully insured and self-funded. They're paid in per employee per month, but that's only one part of their compensation. There's a bunch of back-end compensation. That's why they're coming to you saying, like, hey, if you give me this, I'll get you into this. That's that. In the Health Rosetta world, we decided, because a lot of brokers are transitioning their practices, and then they have some clients that are fully insured, rightfully so. And so rather than saying you can't do anything else, we say you have to disclose all of your compensation sources, direct and indirect, and at minimum. So that's the minimum of a Health Rosetta advisor, is that they completely disclose all of their financial conflicts in writing to their clients. The more sophisticated Health Rosetta, and actually most Health Rosetta advisors are either moved or moving as much as they can towards this entirely. They don't take overrides, they don't get commissions off of stop loss insurance, they don't do any of these sorts of things, and they only make a per employee per month fee from their employer. And that's where most Health Rosetta advisors are, and we're going to introduce tiering in the future that will allow for more advisors that are adhering to that higher standard to have a higher level of reflection, we'll say. Did that answer, Clint, did that answer your question? Did that answer your question, Clint? Or, I think that's Clint, I can't tell.
Can you tell us what is the average average percentage of a self-funded plan where the claims that go to primary care, so that we can use that number to offset our costs? So, if it's 12,000 and 5% is primary care claims, they're going to spend that anyway, and we're going to get rid of that dollar amount for them.
Yep, you're right, 5%. That's a good rule of thumb. 5% is a good rule of thumb.
Okay.
4 to 6%, that's average. I would also, especially if you dispense pharmacy, adding in that, all the drug things, because there's been a lot of movement on, unfortunately, where all the generic, the generics going from $5 to $500, and so a lot of you that are doing prescribing as well, and are able to in your states, try to look into that as well, and that's a lot harder number to give. It requires actual analysis, but probably 5% of pharmacy is a good baseline conservative number of the types of things that you can usually dispense. Is going to be about 5% of pharmacy spent, and pharmacies 20 to 40% depending on the plan. The worst is 40, average 25, 20, depending. You tell. Yeah, I'm verifying down here with a couple Health Rosetta advisors. Sometimes it varies. Pharmacy varies a lot, but roughly 5% of pharmacy as well. Those are the two baseline things that are probably going to hit it. Yeah.
Yeah, so my name's Kyle Rickner, a direct primary care physician, and thank you very much. This was incredibly informative, but it also shows us exactly how much we do not know. And as doctors, it shows us how much we do not know.
Likewise.
And although we're mostly smart people in the room, this is just an area that we don't dive into. However, as we engage employers and we engage their plans, we are forced to be at the table vetting, and often there are brokers there, which many of us will tell you is the biggest barrier to that situation. So my question is, what recommendations would you have for us initially as we have that level of engagement, I guess an initial screening or vetting? And then the second question is if we have someone that we feel confident about them, how do we engage them in Health Rosetta, a broker, from a broker perspective?
Yeah, so any great brokers that you know and that you've done work with, please introduce them to us. We want to meet these people because they're so rare. We think 10% of the market maybe is really well suited for Health Rosetta. And the way to do that is to just email Sean@healthrosetta.org, or send them to healthrosetta.org. There's links for them to apply. And if they apply, tell them in the application when they apply, we ask who referred you. Ask them to put your name. So anytime we see a referral that says doctor or anything, Even if we don't know you personally, we're going to look into it to figure out who you are, because any doctor that's referring a broker means something's up that's probably interesting, because it doesn't happen very often. So that's one thing. And then how to screen brokers and what to look for in them and what to do with employers. First thing is leverage the fact that employers trust you more and bone up a little bit on employers and say, hey, really, to do these things really, really, really well around the rest of your plan, and for me to maximize my effectiveness, we need to make sure you have a broker that does this. And that might mean being a little bit confrontational, passively even. But doctors do trust, or employers trust doctors more on whole. So even if it doesn't get you entirely and doesn't save the deal, it's going to plant that seed of distrust in their broker. The second thing of what to look for in brokers is people that have self-funding experience, which is the minority of brokers to begin with. People that are reaching out to you, not in response to a particular client asking for it, because that's indicative of someone that's trying to look for solutions at minimum. Ask them how they typically get compensated, flat out, and just kind of create an air of exclusivity of like, I only work with brokers that are going to be aligned with what I'm doing, and things like that. I'm trying to think of what simple things to talk to brokers about. Don't equate with them being at a big or a small firm with anything. Like we have people from big firms and small firms in Health Rosetta, and they're great. Look for people that are, so this is, I try to sniff out people, brokers by default are very transactional. And so I try to sniff out transactionalness, if that's a word, pretty quickly in our screening process. And if it smells like they're just trying to like do deals or that, they're probably not right. Yeah, so I look for people that are just trying to like, they aren't thinking about relationships, they aren't thinking longitudinally. Hopefully is that helpful a little bit? Okay. Oh,
Hey, Sean.
hey Patrick.
So, Patrick Roll, DPC Doc, Lancaster, PA. I have the benefit of working with a Health Rosetta advisor, Tina Wilt, who works about a mile from my office. And we have a good thing going there with Paul B. This is my first Hidden Summit. I viewed most of the videos from last year's Hidden Summit. The one that stuck with me particularly was Jeremy Smith's presentation from last year. And I thought his concept of taking time to build that wraparound health plan was absolutely crucial. I work with 13 employer groups. I'm bolted on virtually all of them. I'm probably built into maybe 2 of them, including the Paul B project, or maybe that's a more wraparound type things. But my question is, how can we replicate in each of our local areas what Jeremy Smith has done in Nacogdoches? What's our first steps? Who do we talk to? Do we get together with an advisor? Does the advisor do it? What role can we as physicians play in facilitating development of those wraparound plans?
So get together with Tina, because she is working on something like that. So that's at core what the Health Rosetta platform that we're building is the ability to build these types of plans more easily for Health Rosetta advisors. And then we're also starting to look at what that could look like, a version of that for the DPC doc organizations that have gone to the extent of like, we want to build entire plans and what that looks like. And so we're not there yet. So probably not this year's plan cycle, unless you already have something going. If you are, we're doing something like Jeremy Smith talked to me, like, because we want to take that. In fact, Jeremy and I were talking last night about trying to bring what they're doing onto this to make it easier for other people to adopt it, so that Tina could use something that he did, or someone else could use something that they did, and things like that. So the first steps would be find an advisor, ideally a Health Rosetta advisor, and start brainstorming with them. And I would be I hate fake work. And any amount of like trying to put together the plan and create this perfect thing without a specific patient zero in mind that you want to go to it with, or that you are going to it with, is largely going to be fake work. Like, so don't focus on all the like details of the plan, blah, blah, blah. We can sort that out. Between Tina or any health Rosetta advisor and us, we can figure it out. The most important thing is finding patient zero. Like, who are we going to do this for? And let's do it for them. And then let's do it for another one of them, and then another one of them. That's what Dr. Smith did. That's what everyone does. All of these DPC players that you see, they're more mature and seem to know everything about plans. They just found one person and said, well, I'm gonna come hell or high water, win this deal, so I'm gonna make it up and figure it out. So that would be my other bit of advice. So find the right advisor, and that's a health Rosetta advisor is a good solid bet that like every health Rosetta advisor you would talk to would definitely be on board with this. Some of them are more convinced of the cost savings of DPC than others, but generally they're all they're all in agreement about it. And then together find a patient zero and partner up on it, and win patient zero, then one, then two, and leverage us along the way. Like literally, if anyone that's actually working on a client, we have a hard time right now. We have a small team and lots of growing pains right now. We have a hard time working on hypotheticals right now, but if you're working on real ones, let us know, and we can help architect those out.
I have a question on total insurance cost. On average, how much is like spec ag and then stop loss to the employer? And I get that we could save 5% in claims in pharmacy, but I would think that the majority that we could prove quality would be not hitting stop loss and large dollar claim reduction. Are we monitoring that to see with DPC and outside of DPC? Is there more savings with DPC being involved in the long-term risk and cost to employers?
So, is One Beacon still here? Christy and Julie? Julie, could you yell out, or Julie's not a yeller, so maybe we should bring the mic over to her. So One Beacon's a stop loss carrier. They're one of the ones that get DPC. They were actually at Hint Summit last year, and we've built some custom kind of approaches to stop loss with them around this. Could you just real quick give your rundown on that piece of how I'll let you answer that question first.
Okay. Well, I'll start out and then pump me a little bit if I'm not fully answering the question. So what we're really seeing is that when you put DPC in, everything else is escalated. So all of the other things that Sean was showing, those types of programs are escalated. So while we might talk about 5% for DPC, 5% of the drug spend if you're also prescribing, if you're putting in a number of those other things, we're easily seeing 40 to 50% savings. And that happens when DPC is part of the plan. It's harder to get those other things to work if you don't have the DPC on board, who has a little bit of knowledge of the plan, is making sure that the other facets are being used. But the plans we've built right now are seeing 40, 50% savings, and that's even considering, they've got claimants running in from prior plan designs and that sort of thing. So we're really expecting to see some pretty significant savings.
Yeah, and think of DPC as like an accelerant for the underlying things in the plan. But the converse is also true, that if the plan is just doing DPC and not other things, it might affect ag, but it's not really showing much effect on like the big claimants yet, at least from stop loss, from all the stop loss carriers I've talked to, is that if it's DPC alone, like a bolt-on model or bolt-in,
Right.
You're seeing a lot on this, and just, aggregate claims, the premium for that is tiny compared to your claim, the premium you pay for your spec, for your high dollar claims.
Right. Certainly there could be some cost avoidance on a high dollar claimant, but really the aggregate is kind of where you see the DPC effect. All of these other programs have, the real problem is if all you have is DPC and you still have like a BUCA PPO plan, something with United Healthcare, there's restrictions on the DPC too.
Yeah.
So, if the infusions are taking place in the hospital and the hospital can charge whatever they want just so they show that 60% discount, stop loss knows that's happening.
Yeah, and so.
Hey, Sean, can I jump in?
Yeah.
So we are Nova, and we have a self-funded plan that has, we view it as a wraparound using one beacon as on the stop-loss side. And as of right now, they're about 10 months into this year, they're running at 37% of the max attachment point. So that's significant savings over what would have been projected as their costs based on their geography, their demographics, and their past history. So that's a significant
And
savings from
what
our
else-
standpoint.
What else is in the plan besides DPC?
So, well, DPC is at the center, and this particular DPC doc has negotiated rates within his community for imaging with specialists. He has a pharmacy that he's getting significant savings on. Everything that he refers to as zero copay, zero patient out of pocket, and then it's wrapped around with reference-based pricing for anybody who goes outside of his circle.
Okay.
And he's got about, I think it's about 93% of the membership is utilizing his practice.
Yeah. So that's it's like a compounding power when you put DPC together with, the big one is replacing traditional networks, like, unfortunately. And that's the hardest thing to do for an employer, because as a member, it's scary to not have Blue Cross Blue Shield. Like, there's been all these studies like, oh, how do you get health care? Oh, I get Blue Cross for I have Blue Cross for my health care. No, you don't. You have, you don't.
So I'm a TPA based in Kansas City. We've been doing DPC wraps for 5 years now. And the question about what the cost is a lot of it depend on the size of the plan. Small groups obviously have a higher cost for their stop loss coverage. But I can tell you that anecdotally, we know that DPCs have impacted catastrophic claims on a case-by-case basis. Yeah. The challenge is going to be over the next 7 to 10 years is to develop the data so people like One Beacon and the other stop-loss carriers can actually provide a lower cost of stop-loss coverage. And it's going to affect everybody. You guys are doing a great job at mitigating risk by reducing it. The problem is the actuaries and the stop-loss carriers yet don't have enough data. They got to have more data. This whole thing has been about data today or yesterday. We talked a lot about data. And that's really where the rubber meets the road. Those stop-loss carriers are looking for the data that can substantiate a reduction. And overall, there's some great opportunities in this area. But to answer your question, the stop-loss contracts right now still reflect the old mindset of what healthcare costs are about. And we haven't gotten to a place yet we have enough data. So I hope that answers a little bit of the question.
Yeah, and that's a good point also of like how there's way more going on than any of us know, is because here's a TPA that's been doing DPC for 5 years and we don't know each other at all. And that's really exciting to me because that means more is happening than we think. In fact, Tina just got an RFP yesterday. Someone randomly bought Dave's book and went through it and created an RFP out of the book, which includes value-based primary care, and sent it out to a bunch of brokers. And that was exciting to me because I haven't even written an RFP off of Dave's book, so for others to use. So that's super exciting. But yeah, exactly to your point, that we are seeing some carriers, if you're doing DPC and then a few other things, giving some discounts. And most importantly is that aggregate claims factor on DPC, is that stop-loss carrier that's at least willing to affect that aggregate claims, because that's going to affect the max out of pocket. And that's the most likely thing that they are going to adjust, largely because it's not where their costs are. If they get it wrong a little bit off, it makes them look a little bad, but it doesn't hit their books the same way that getting their spec projections off and pricing off.
Sean.
And ag and spec are terms for specific deductible, which is cancers, expensive stuff. That's really what stop loss is. And aggregate deductible, I'm very much oversimplifying, which is your total spend as an employer.
Sean, hey, thanks for being here this morning. So we recently signed an employer who had 189 employees, so we're really excited. And then they only actually brought us 75 because as we looked at their book of business, they had a lot of $14 an hour staff, and it turned out a lot of their staff were on Medicaid. And Medicaid has been somewhat toxic, not because family physicians or whatnot want to avoid Medicaid, but it's been really complicated. It creates complications in the employer market, I feel, because there's churn. People have Medicaid 1 month and not the next. In my state, the regulators came out and said, you can't be on a DPC if you have Medicaid, and they put out like a little edict, and we had to disenroll like 100 people who had Medicaid and were paying their own subscription because they'd rather see us than go to their Medicaid assigned provider. I'm very concerned about this. What is Health Rosetta's? Can you just summarize like what the thinking is on what do we do with Medicaid and how? Because I think this is a big problem in the future. Particularly if we go to Medicare for all, which will actually be Medicaid for all, right?
So, how to avoid this rat's nest? So Medicaid state by state, I'm assuming most of you in here know that. What he's describing varies significantly state by state, what the rules are. It's administered by the states. You got everything from the states that have gotten block grant exceptions of things. You got states that are doing managed care kind of models. There's like 27 states or something that have some version of that. And then you've got kind of fee-for-service Medicaid kind of making up the rest. And it varies significantly from place to place. I'll tell you the self-interested answer rather than the policy wonky answer of what we think is, what we're hearing is potentially happening. And generally when we talk about stuff, we don't generally have opinions. We're basically just parroting opinions of people that know more than us. So, as I said, king of the hill. But the pragmatic self-interested answer to for your self-interest is talk to brokers about, when you're talking about a deal, what the participation rate is of the company and what their turnover rate of the company is of management and of line workers, and avoid places with high churn, unfortunately. If I were you and I were purely self-interested thinking, I would be looking for like manufacturers for cost savings types of things where like a CNC machinist is just as valuable as a software engineer to a company and just as hard to find, but one makes $80,000 a year, one makes $350,000 a year. And one works for a company that works on 5% margins, one works for a company that works on 30% margins. And so they're very stable. Manufacturing jobs have very stable workforces generally. They have long turnover, so they're very well suited for DPC because they're in a tight labor market. They have limited, and spending $1,200 extra a year to make someone feel like they have spectacular health care will do wonders for those types of organizations. So I would avoid places that like retail and things like that from a purely self-interested. Again, like capitalist hat versus how you want to practice and who you want to help hat. So that would be my answer to that is I don't know what to do about the policy things, and I don't know, yeah. We'll let Jay take the more heady version of the answer to that, and I'll do the more pragmatic of look for, my favorite organizations for Health Rosetta type plans, including DPC, is industries where you have low average margin and high average salary. And what that means is they have a non-fungible workforce, but their market demands means that they have limited options, they have high competitiveness, and that puts them between a rock and a hard spot. These are manufacturers, these are certain types of professions, things like that.
So,
and that's wait, real quick, a broader point is, unfortunately, I think one of the original sins of healthcare is that 40 years ago, all of your physician grandparents were lazy about sales. And so when someone came along and said, I'm gonna give you everything you want, all the money, and you're gonna make a bunch of money, you're gonna be well respected in your community, but when I say jump, you say how high. And they said, cool. And then it flowed from there. One of the original sins, not the original sin. And so you haven't got a chance to like learn marketing or how to like hustle, or naturally you've had to, everyone here's had to like build those skill sets. And so thinking very deeply and learning about how segmentation works and how channels work in marketing will be a very valuable skill because it'll increase your close ratios. Because if you're going to a bunch of manufacturers, or if you've won one manufacturer and go to a bunch of other ones, we're all tribes. We're all like hunter-gatherers still biologically. And so it's a lot easier to win. And so segmenting on who you're going to and then channels of how you're gonna reach them, like learning a lot about that will make a huge difference, because if you close double the number of things you talk to because you're segmenting better, you've just doubled your growth rate. Or if you cut your sales cycle in half, you double your growth rate. Oh, sorry.
So my question is, as a new family doctor going out doing a DPC practice this fall, this is a ton of new education for me, things I've always wondered about and learning a lot about. I don't feel confident to be able to go to the table to some of these employers and say, here's what it is. The advisor is a huge key to that. How do we get in touch with people? And is there a website?
Yep.
Is there something where we can make contact with advisors near us?
healthrosetta.org, and then there's a Who We Are page, and on that has all of the Health Rosetta advisors on it, and there's a link on that part to a map of where they are, and so just find someone near you and reach out to them, and they'll generally be happy. And if they don't reply to you, just email us directly and say you're wanting to meet someone in your geography.
And is there something we can go and as doctors on your Health Rosetta website where we can put our information in as a resource contact for those advisors who are looking for business and that avenue?
That's what we're working on with Hint, to make that answer, to tackle that on steroids.
Thank you.
I think Garrison had a, I'm sorry.
I have a question.
Hello?
I'm not going to go in front of Garrison.
Sorry. I wanted to make a comment about the Medicaid question.
Good.
Because, as you know, Q-Line's had considerable experience with Medicaid.
A little.
Yeah, like 30,000 people. We had a lot of experience with Medicaid. I think that it's one of those, do not try to do this yourself at home. So anything that touches Medicaid is toxic to primary care. And we've proven it over and over and over historically, and we approached this with tens of millions of dollars of venture money, and it took us out. So you have to be very careful in that arena. So they don't pay for what we do. They're not designed to do that. They actually punish what we do. So as much as we loved the idea and wanted to do it, and all of our docs wanted to do it, the danger is enormous, and until they fix that, we should probably develop our reputation someplace where we can really make big inroads and have huge impact. We were, by the way, able to dramatically reduce the cost of Medicaid, and 5-star reports from our patients, and that was financially lethal. We never got paid for it.
That was the example I was thinking in my head of why I gave a very think of your self-interest answer. And the analogy we use broadly is, from a systems change perspective, it's not like the whole country turned off gas lights one night and then turned on, we had National Electricity Day. And we all turned it on, we're like, awesome, we all have electricity. You had to figure out where and when and how you were gonna do it. And so in our minds, we're still early enough. Everyone talks about early adopters, the adoption cycle. We're not even in the early adopters if you look at the percentage. We're still in the champion stage. So finding people that are deeply passionate about doing these things and getting through that, then we'll get to early adopters, then we'll get to our early majority. And someone had a question over here,
Yeah.
I thought. Oh.
I've got one, Sean. So in the self-funded employer world, where typically, if we talk about the example of carpal tunnel surgery or a inguinal canal, inguinal hernia surgery, you're referring to a specialist, a surgeon in that case, and it's elective. You're choosing your private orthopedic surgeon or your private general surgeon to do that procedure, and oftentimes they're being paid at the UMR contracted rate. So can you talk about in your ideal circumstance, how is the check from the employer getting to the surgeon, and who's negotiating that rate for the carpal tunnel or the inguinal hernia?
These are really good leading questions that you know the answer to, in some part at least. Okay, so in this scenario, you have DPC and a traditional network through UMR, right? That's what you're assuming, like a PPO network? Okay. So employer has a bunch of money that they're targeting to spend on healthcare this year. And then every week, typically, or every month, typically every week, the TPA says, well, you've had this amount of claims that we need to pay. You need to transfer this amount of money. They contact the controller, and TPAs, you can correct me on any little nuances I might get wrong. They contact the controller, and it's a bit more automated this, but let's assume a fully manual process. They contact the controller says, okay, great, I'm gonna wire you $250,000, or bigger companies, $10 million. I mean, you think of $15,000 per employee per year for a company like Lowe's that has 185,000 people on their plan. We're not talking small amounts of money. It gets wired into an escrow account for a trust account, because ERISA plans are technically a trust, just like you'd set up for your kids or something like that. For all of you DPC docs setting up trusts for your kids already. It's a trust, and so that goes into that trust account for the ERISA plan, and when you get into in the public sector, it gets a little different, and when you get into like MEWAs and captives and all sorts of other things, it gets a little different. So there are all variants on a theme, but this is the basic flow. That money goes into that thing, into that trust, and that's the money that goes to used to be paid claims, and it goes every week. Money goes in. So that's where the money comes from, on the demand side. Then on the supply side, so you refer out, it goes to the doctor. It's the world you all came out of. They go in and use elation, or sorry, they don't use elation. They use Epic or Cerner or whoever they're using, and they do that claim. That claim gets submitted into the TPA. There are TPA, like claims clearinghouses, that basically aggregate all of these claims that then get fed to the TPAs in a less than sophisticated way in more cases than you would expect for something of such large volume. And that goes in, that claim comes in to the TPA, and they have claims processing systems that the plan is set up on. That plan's setting up what's the deductible, what's the out-of-pocket, what is our provider network contract rate, like what are we supposed to pay discounted of bill, blah, blah, blah. So the claim comes in, and it gets repriced. Well, the claim comes in, if they're using I'm gonna avoid complexity. Let's just assume TPAs are laughing over there. I'm trying to simplify this down significantly. The claim comes into that system, it gets repriced, the doctor bills $60,000, and it might not come at once. It might have separate bills coming in, might have separate bills coming in. It will have separate bills coming in, and the anesthesiologist is gonna send in 2 bills because they're anesthesiologists and that's what they do. And then you're gonna have bills coming in from the facility, and ideally that's all bundled up as the DRG, but that's not always the case, and some things are out. And so most TPAs aren't assembling that into a bundle behind the scenes to understand the episode of care, unless there's a need to manually review it, and then they have clinical people that put it all together. But the claim comes in, it gets repriced in that system, and then it gets batched every week to then get paid out to the doctor. And the doctor then gets paid back, and the facility gets paid, and the anesthesiologist gets paid. Ideally, at that contracted rate, ideally. That doesn't happen as if you've ever been in independent practice before in a fee-for-service world. You get clawbacks and things like that because, surprise, I'll not be negative. Technology is not as sophisticated at determining those contracted rates because they vary from plan to plan to plan to plan, and client to client to client to client within that. And so that's how the money flows on that. Is that the question you were asking? I want to make sure I'm hitting all of it, because this is a rat's nest.
This was supposed to be easier than Medicaid. How does
not.
Health Rosetta make that better because of the fact that that's a huge amount of the spend, and we, the DPC doc, can affect that because we're going to send to the surgeon. But the problem is when the rate is the UMR contractor rate for the inguinal hernia, it's $8,000 and not $2,000. So that's a lot of work to make that happen. So how does Health Rosetta help with that?
Thank you. That's a better answer, or a question that I can better answer easily. In the world of transparent open networks, which are a very nascent, if you think DPC is nascent, transparent open networks is even more nascent. Nascent, one of those, nascent. And there are various approaches to this. The most common is, you've probably heard this term reference-based pricing, and it sounds fancy. It's not. It's just some sort of market clearing, some approximation of a market clearing price, the most common of which is Medicare, but there's also cost to build, because like Medicare doesn't cover like childbirth or pediatric or things like that, so you've got to figure out some other reference. So cost to build, or your charge ratio. It's also, we've seen references like if a hospital is like 5% profitability, then you have, that's the reference, and is like, we'll pay you 10% above whatever your profit margin is, things like that. And so in that version of it, what you do is you take that reference, and then there's a direct contract between the provider and the employer in an ideal world, and then sometimes with an intermediary that like bundled procedure networks or direct contracting platforms or cash pay platforms. It's all variants on a theme. And those people are going out and signing these contracts and aggregating them in one place, and then they sell that service to employers, and they pay a per employee per month or some other model for that. And so the way that we help with that in a Health Rosetta world is this is where it gets into bolt on and bolt in versus built around. So when you on the continuum towards built around, you get more and more of the care that's downstream that is going to get repriced from the billed charges in a more simple way, or doesn't need to be repriced at all because there is a direct contract in place. The challenge is that, and I just learned this not too long ago. I was talking to a hospital CFO, is they don't actually have any way to put a price into their systems. All they can, and for some hospitals, their only way they can put a price is our billed charge and what the discount is. They can't put $10 in or $1,000. And that sort of blew my mind. So there are some complexities of that, but the way that we simplify it is there's alternative ways of contracting that use a reference for some sort of approximation of a market clearing price, and then either reprice that down to that on the fly, or in advance set up some sort of contract that does that for a single service or a bundle of, like a bundled procedure services. Like, I'm sure you all know Keith Smith from Surgery Center of Oklahoma, that style where you're bundling everything up. That's the model. Is that a better answer? Probably still more detail, but you use some sort of approximation of a market clearing price, and then you create an actual contract around that and pay based off of that because it better reflects reality. All right, are we done? Sorry, we went way over time.